My name is Fred Fahey. I'm a nuclear medicine physicist from Boston Children's Hospital. And for another 24 hours, I am the president of the SNMMI. So I will look a lot happier about 24 hours from now once I get through the plenary without tripping on the stage. I want to, welcome all of you to come to this program. And I remember, I guess it was in Palm Springs when we first had our first meeting of the Patient Advocacy Advisory Board, and ever since that I try to make it into my schedule. They usually put about 3 things I'm supposed to be at the same time, but I love meeting with the Patient Advocacy Advisory Board because they're such an energetic, enthusiastic, looking for solutions kind of group. So this is a really great opportunity for me. And thanks, Josh and Simon, for inviting me, because in leadership, it turns out that the only talks I get to go to are the ones I give, and so. With that, what I've been asked to talk about today, as I told you, I'm a nuclear medicine physicist. I'm not a physician. So if Summer really did fall there, we were in trouble because we didn't have a physician here, but I'm glad she didn't. What I'm going to try to talk to you about today is radiation in the context of nuclear medicine. So what I'm not talking about is radiation therapy. I'm talking about in the context of imaging, and what perhaps you might want to know about imaging, and happy to try to answer questions when you're done. If you think of some questions later, here's my email address, and feel free to email me, and I will do the best I can to try to answer your questions. So if you may perhaps be a little bit confused because sometimes you'll see nuclear medicine, you'll see molecular imaging, and are they the same or are they different? So when we talk about molecular imaging, we're talking about using some kind of agent that follows a certain pathway, physiologic or functional pathway within the patient. Maybe we're measuring how well the kidneys work, or maybe we're measuring how well the brain works, or something like that, and then imaging that molecular or cellular pathway. So what we're imaging is really how the body or a part of the body works more than we are how it looks like, what it looks like. And so that's how it's perhaps different than radiology, other parts of radiology. And I'll tell you why that's important in a minute. And some of the agents we use are radioactive, and so we administer to the patient a small amount of radioactivity, and then we have specialized detectors that can measure that. And when we do that, that's what we call nuclear medicine. So nuclear medicine is a part of molecular imaging, and probably these days the large majority of molecular imaging performed in patients is nuclear medicine. Now, nuclear medicine uses safe, painless, cost-effective techniques to image the body and treat disease. We use, as I just said, a small amount of activity, and as I said, we're looking at how the body works more than what it looks like. There is also a therapeutic side of nuclear medicine. I don't know whether any of you have known people who have had thyroid disease or thyroid cancer and got radioiodine therapy, and that's nuclear medicine, but a therapeutic side of nuclear medicine. What I'm mostly going to talk today about, though, is diagnostic side of nuclear medicine. And again, why is it important? Well, it's important because what we find is that often when we're trying to treat tissues, we see that functional or molecular changes happen a lot sooner than anatomical changes. So, for example, if you're looking at a tumor, we'll see functional changes long before we see the tumor getting smaller. So we could see functional changes within a day. If we do a treatment and it seems to be effective sometimes, not all the time, but sometimes we'll see that it's having an effect right away within a day, as opposed to waiting for the tumor to get smaller, which is going to take weeks. So that's one of the advantages. And it allows us to look at the physiology of you. Often when we base on what medicine's going to be is we assume, well, this is this average person and we give this dose. When you read how much aspirin you should take, that's based on a dosage for the average person, right? Whereas what nuclear medicine allows us to do is look at not just everybody's physiology, but your personal physiology, and perhaps that's going to be more useful to your doctor to try to figure out how your doctor is going to treat you. What our hope is that information is going to be helpful in trying to tailor your treatment. And you'll see this statement a couple times. It's part of our position statement we made at last year's annual meeting in Miami. When nuclear medicine is performed with the right test, with the right dose, on the right patient at the right time, the benefit of that test way outweighs whatever small risk I'll be talking about in this lecture. As I said, there is therapeutic versions, and the one that you mostly may have heard of is people maybe with sometimes not even cancer, Graves' disease, for example, will get I-131 therapy, and the iodine-131 goes to the thyroid, and it treats the thyroid, and it doesn't pretty much go anyplace else. So it's a very targeted way of delivering radiation therapy. In the last few years, we've seen more targeted approaches, radioimmunotherapies. You may have heard of them, or even had the opportunity to use these therapies that have been used to treat lymphoma, neuroblastoma, and most recently, within the last month, a new agent, nuclear medicine agent, has been approved by the FDA for treating metastatic prostate cancer. So that's a very exciting therapy that's just been introduced. But as I said, I'm going to mostly be talking about diagnostic nuclear medicine. So how does that work? So in this case, the patient's injected, as I said, with a small amount of radioactivity. That radio, depending on what that pharmaceutical is, it's going to go distribute in the body according to some physiologic pathway. In this case, it's going to be looking at blood flow to the lungs in this example. So some of that agent's going to go to the lungs. If the lungs are getting good blood flow, we put the patient under a camera here. You see these two cameras. The patient's lying on a table. These spin around, or sometimes spin around the patient, or maybe they're just static. And what you get is an image of where did that radioactive drug go. So what we're measuring is where did that drug go. Usually you take aspirin again, and once it's in your mouth, you knew it was in your mouth when you put it in your mouth, but after that you have no idea, right? In this case, we are measuring exactly where it went. We can measure the rate at which it got to the organ, the rate at which it left the organ, and by taking all that information into account, we can make some judgment. In this case, it looks like, well, both lungs have about the same blood flow, which isn't always the case. There are usually two different kind of cameras. How many people here have had a nuclear medicine scan that they know of? Okay. So you probably can do this slide for me if you wanted. So usually there's two kind of cameras. One of them you'll see there's one or two cameras. You lie on the table and these spin around you. And it's called a nuclear medicine gamma camera or a SPECT camera, single photon emission computed tomography. And in other cases, you go into a tube that sort of looks like a CT scanner, except in a CT scanner, it's a fancy X-ray tube. In this case, there's not an X-ray tube if it's just a PET scanner. It's looking at the radiation coming out of you, and that way it's able to tell where did the drug that you were administered go. In most cases these days, PET scanners are incorporated into CT scanners. So you have one scanner that sort of measures the anatomy by looking at the CT scanner, another one that's looking at the function, the PET scan, and then combine so you can tell where the radiopharmaceutical went. And I'll show you a couple of examples. Well, right here. So for example, in this case, you can see that this is a whole body PET CT scanner. So the part where you see the bones and that thing is part of the CT scan, and the part where you see the liver here and the heart and other things is the PET part of it. So if you ended up having some activity that you didn't expect, for example, maybe this, then that shows you that there's a potential of someplace in the body. And in this case, we're using an agent that is fluorodeoxyglucose, or FDG. You heard the word glucose. You might know that that's sort of sugar. That means sugar. And so what we're looking at basically is what tissues are burning sugar faster than others. Those that show up right are metabolically active. They need a lot of energy, and they're burning sugar fast. And that and thereby it has a high uptake. And often, as you've probably have heard, tumors and cancer often is more metabolically active than normal tissue, and so this is a way of indicating perhaps that this is a tumor. Again, I'm a physicist, but I think that it's a likelihood that this could be a lung cancer, for example, a place in the lungs that doesn't look like the rest of the lungs that has a high uptake of FDG. So that's what it allows us to do. But because we have the CT, we can tell, yeah, it's in the lungs, because sometimes it's not that easy to tell. This scan here is a myocardial perfusion scan, a SPECT scan. So this is a very common, sometimes you'll hear, oh, I had a stress test. So what we often do here is we inject the patient, and we do a study with them at rest. And this is the heart. To look at this is think of the heart, and we're measuring the muscle of the heart. So think of the heart of sort of a bowl in the left ventricle, and the blood's in the middle. What we're measuring is the part of the muscle that's doing this. And so if you slice through a bowl this way, you would get an image that looks like a donut. If you slice it this way, you get an image that looks like a U. And so here's the donut part, and here's the U part, slicing it this way and that way, okay? So it looks pretty uniform. The bowl looks reasonably uniform, and that's good. Now we put the patient on a treadmill and say, walk really fast here. We're going to inject you now, and we're doing a stress test. And perhaps under stress, some parts of the heart don't get blood flow here. But the fact that it did get blood flow over here tells you that this part of the heart is not dead. It's just ischemic. It's not infarcted. It's just ischemic. And maybe if we return blood to that part of the heart, it would come back. So this patient may be a candidate for bypass or angioplasty or something like that. And that's how this test is used. And here we have another PET CT scan of a brain tumor. You can, and you can see here the tumor on this scan. You can see it on the PET scan, with the high metabolic activity of this, because this is, again, FDG. And then you overlay them, and you can tell pretty much exactly where that uptake is. These are just a few examples. So what is radiation? We're measuring radiation coming out of the FDG or whatever the agent is that we're using. In the case of the heart study, it was technetium-99m sestamib, or MIBI, and that's some energy given off by the material that's been administered. Now that energy might be a gamma ray, it could be a positron, or it could be both. And so can we measure that? Well, if it's high enough energy and it gets out of the body, we can measure it. If it's lower energy, it may not get out of the body. Things like visible light, you can sort of maybe see visible light through your fingers, but certainly not if you try to shine it through your whole body, you know, microwaves and things. That which is energetic enough to get out of the body is more in the range of X-rays and gamma rays, and so that's what we use often for imaging, both in radiology and in nuclear medicine. And as we'll talk about, maybe too much ionizing radiation can damage tissues. And that's what we'll talk a little bit about in this study. So in general, the scanners that we use in nuclear medicine, the SPECT scanners, they don't give off radiation. They're measuring the radiation coming out of you after we've administered this radioactive drug. In the case of a PET CT scan, it's both. It's measuring the radiation coming out of you from the FDG, but also a CT scan that does emit radiation on top of that, so that you can see, so you have both the anatomy and the physiology. Small amounts are used because our detectors are so sensitive to measure this, so it's really a small amount. For an example, the amount of iodine we have to do an iodine scan, not a therapy, but a scan, is so low that even if you were allergic to iodine, it wouldn't matter, because we're giving you what we call trace amounts, very, very small amounts, and that's all we measure. For therapies, like iodine therapy, you would give larger amounts. The gamma rays are the same family as visible light. It's some kind of, it's like light, except at a different color. And in this case, color is equal to energy, and you might, if you're really close up front, you might see that there's actually different colors here. Here's infrared, here's ultraviolet, and all the rainbows in between. If you go up much higher in energy, you get up to where we're looking at gamma rays and X-rays, and those are the ones that can get out of the body and allow us to measure it. Now, the unit you might see, and it's just a unit of the amount of radiation that an object or a patient receives, is called the millisievert, named after some famous physicist, millisievert, so 1,000th of a sievert. The traditional unit that you sometimes see might be millirem. And they're just related by this way. 1 millisievert is equal to 100 millirem. So you might see some articles or some information with using this unit. These days, more commonly, you'll see this unit. And it's a measure of how much radiation the patient received. Now, we're exposed to radiation every day. As we walk around, we live in our houses, and even there's some radiation in our body. We have potassium in our body, a very small fraction, very small part of 1% of the potassium is actually radioactive in our body. And there's other amounts of radiation. You may know that there's radiation in the soil, particularly in certain, if granite has a higher level of radiation in it than perhaps some other, just dirt, for example. And then some comes from outer space, emitted from the sun, emitted through space, and comes from outer space. And then there's some in our basement, we know, right? We buy a new house, we have to have the basement tested for radon. And that radon gives us some radiation as well. And if you add that all up, you get about 3 millisieverts every year. Every person in the country, on average, gets 3 millisieverts per year. 2 millisieverts of that comes from the radon. And that varies depending on whether you live in a brick house or wood house and in different things. But on average, that's what it is. But the average person in the country gets 3 millisieverts. Now, it may change a little bit depending on where you live. If you live in the mountains in Colorado, you get a slightly higher because the dirt tends to have a little bit more radiation and you're higher up, so you tend to get a little bit more from outer space than if you live in New Jersey. Okay, so, but not too much different, but on that order. So you could say 3 to 4 millisieverts is what someone gets every day, just from nothing that has to do with medical imaging or anything. In this pie chart, it shows the average radiation that a person in the U.S. gets every year. Now, this is average, right? So that means that not everybody gets this. Some people get more, some people get less. And you got to be a little careful with averages, right? If Bill Gates walks in the door, the average income of all of us goes up, right? We still have no more money, but the average income goes up. Okay, so keep that in mind. So in this case, as you see, half of it comes from the background we just talked about, that 3 millisieverts, and the other half comes from medical imaging. Half of that is from CT scans, and about a quarter of that is from nuclear medicine scans, mostly nuclear cardiology for those people who have had the stress test for nuclear cardiology. Now, how much radiation do people get? Well, when you go and get your nuclear medicine scan or your PET or your X-ray or your CT, the technologist works around radiation every day, 8 hours a day, every day. And the limits that they can get is 50 millisieverts in a year. Okay, so from background you get 3 millisieverts. Someone who works in radiation can get 50 millisieverts. In reality, no one gets, or very few people get anywhere near this. They get maybe less than 1/10 of this. So your nuclear medicine technologists probably get something like 1 to 5 millisieverts per year from their job. And here's some other things. Old TVs particularly gave off a little bit of radiation. Those of us like myself who flew up from Boston got about 0.05 millisieverts just flying across the country, because you're higher up and the stuff from outer space is more likely to hit you. So that's a small amount. As we said, this is about what we get from background. This is what workers get. Chest X-rays are very low, right? You don't need many X-rays to get through air, and most of your lung is air. So that's a very low dose. If you look at the rest of these things, they're on the order of several millisieverts. So a nuclear medicine lung scan is 2, a bone scan is 4, mammogram is about 1/10 of that. A CT is on about twice that, for example. And then a PET CT scan, where you combine PET and CT, is about maybe 14 to 20 millisieverts for an exam. Depending on how it's done, it can vary a little bit. And these data are on the discovermi.org page. You've probably heard about that before. That's our nuclear medicine page about information for patients. How much radiation is received from medical imaging? Well, you saw something, you saw a little bit about what the average is on that previous slide, but it varies depending on the patient, depending on the equipment, depending on how the procedure was done. So those numbers were rough averages. But in general, from nuclear medicine, it's about the same as other radiologic exams like CT scans, and about equal to 1 or 2 years of background radiation. So about the same you get from 1 or 2 years from background radiation. How much is safe? It's difficult to answer. Exposure to ionizing radiation, particularly high levels, has been shown that it can lead to unwanted health effects, including cancer. And that most of that is by studying for the last 60 years the survivors of Hiroshima and Nagasaki that have been studied for a very long time. And we know that the people who got the higher doses did have a higher levels of cancer, but small, as you'll see in the following slides. There's no real evidence, although maybe some is coming up now, that the radiation that we get from radiology or nuclear medicine leads to these effects. But since we don't really know, we try to be conservative, and so we draw a straight line and say, we'll just assume, because we don't really know, that any little amount of radiation may have some little amount of risk associated with it. And that's what I'll show you in here. That's considered probably a prudent approach, that no matter how small, every little bit of radiation carries some risk. That may be wrong. It might be that if you just get a little radiation, your body can repair and you're fine, but we just don't know, and so we try to be conservative. Are there some people who are more sensitive than others? Well, children under 20 years old tend to perhaps be 2 to 3 times higher risk than adults. They are going to live a much longer time. So if some deleterious effect from the radiation occurred, they have a much longer life over which that can be realized. Plus, their tissues are growing and the cells are dividing, and perhaps they're slightly more sensitive because of that. Whoops. Young women are a little bit more sensitive than young men, maybe by 20%. And that's not just from breast cancer, but it's also from other cancers, it turns out, lung cancer as well. And in the fetus and embryo can be sensitive as well. So these are 3 sensitive populations. I work at Children's Hospital, and we spend a lot of time trying to make sure that we keep the doses to our children as low as possible, where we have many active studies going on looking at that. What is the risk? Is there a risk associated with nuclear medicine? Well, just like practically every medicine that you do or any procedure, there's probably some side effects, and nuclear medicine is no different than that. But it's very, very small, as I'll point out in the next slide. And again, I come back to this statement. Used in the right way with the right patient at the right time, nuclear medicine is a safe imaging modality. From the data that I told you about, mostly from the Hiroshima and Nagasaki survivors, we have decided that 10 millisieverts, a little bit more than some of the tests I showed, a little bit less than others, leads to about 1/20th of 1% of the patients who get a CT test that gave to that dose may develop a fatal cancer sometime in the rest of their life. Not tomorrow, not next week, but sometime probably between 10 years from now and the rest of their life. Okay, that's pretty low, 0.05%, 1 in 2,000. Okay, that's compared to the population. This audience may know more than most that 45% of the population gets cancer and half of those die from it. So 22% of the population. So if you're, if you had a CT scan, for example, instead of it being 22%, it's going to be 22.05%. So it's quite small compared to the normal risk. Each exposure carries its own very small risk. And so the 4th PET scan carries the same risk as the 1st. So if you said, oh, I've had these many tests, and should I have one more? Is that going to put me over some edge that makes me even more sensitive? No. Consider it like crossing the street. Every time you cross the street, there's a risk that that something could happen to you. And the fact that you've crossed it 10 times in the last 2 months doesn't affect the risk of this time that you're crossing it. And think of radiation from medical imaging in the same way. Every incident is independent. In here I've just put a list of what I've calculated, perhaps the risk from a PET scan, perhaps 1 in 2,700, from a bone scan, perhaps 1 in 5,000. And if you look at the risk of dying from a number of different ways, you see that that's sort of on the order of how the possibility of people who die, not just people who have accidents riding a bike or falling down the stairs, but die from that accident. So it's rather rare. I mean, falling down the stairs is rather rare. And again, that's maybe a good analogy. You know that there's some risk walking downstairs. If you're not careful, you could trip. But we still walk downstairs because there's an advantage from getting to from the second floor to the first floor, and we weigh that the benefit of doing that exchange is worth it. You know, and so you make that judgment, and I think that's in a little bit maybe the same way you should consider radiation. And this slide, again, is another one that's an average, and so the Bill Gates thing still exists. And this is like looking at all kinds of risky behaviors, like being male, right? So if you're a male, you lose something like 8 years of your life compared to a female, right? If you are 30 pounds overweight, which I'm sensitive about, then that you lose, on average, about 3 years of your life. If you are a radiation worker, and you work every day for 40 years, you on average lose 25 days of your life. Now, keep in mind, this is this average thing, right? So that means most people, the large percentage of people lose nothing, and there's a few people who perhaps lose a lot. So keep it in that context. How much radiation would be considered too much? More than necessary. However we do the test, we try to decide what's the right amount of radiation to do that test, and that's how we want to do it. Each procedure takes a certain amount of radiation to perform properly, and we're trying to get a better handle on what that is. With new technology, new scanners, new computer programs, we're getting lower and lower all the time. You'll see over the next few years that the dose, for example, from CT is going to probably go down by at least a factor 2, maybe a factor 4, because of the new hardware and software. Using too much leads to perhaps unnecessary radiation to the patient, but maybe using too little isn't helpful either, because it's like you're taking a photograph and it's dark and you get this really snowy picture that you can't really see what's going on in there because you didn't use a flash. Same thing. If you don't have enough light getting into the camera, you don't get a good image. If we don't give the patient enough radiation, we're not going to get a good image. So too much is not great. Too little is not great, and we want to be at the right place. We want to make sure it's optimized. We talk about dose optimization. Oops, going the wrong direction. Is this nuclear medicine test necessary? You know, that's a very reasonable question to ask your physician. So, so you may ask your physician when they want to do a test, whether it's a CT scan or a nuclear medicine scan. How is this test going to change how you're going to treat me? Well, how is the information you're going to receive from this test going to make a difference? And then, is there another test that doesn't have radiation that will give you exactly the same same information? And there may not be. This may be the best test for you as a patient. This test, PET scan, might be the best test. And so, in that case, if patients decide they don't want the test because they're afraid of the radiation, it really is the right test, that could be detrimental to the health if that test is going to give your doctor the essential information he or she needs in order to decide how best to treat you. So keep that in mind. What is the imaging community doing about this? Well, there's a couple different campaigns that have been going on. I work at Children's Hospital, so I've been very active in this group, the Image Gently group, dose optimization and pediatric imaging across all imaging, not just nuclear medicine. But if you go to their website, there's information there for patients as well as for imaging professionals about how best to limit the amount of radiation in pediatric imaging. And that was so successful that the radiologist said, maybe we should do something about adults as well. And so owls are older than butterflies, and so they did Image Wisely, and they have a similar website about dose optimization in adult imaging. Us at the SNMMI worked closely with the Image Wisely group about a year ago and worked on putting together the nuclear medicine website of Image Wisely. So if you go here, you'll be able to find the nuclear medicine website with a lot of, again, information for patients there. Both campaigns promote the appropriate procedure for the specific patient with a minimum radiation dose necessary to provide the appropriate and useful information to the physician. In addition, you can go to our website, and we have recently launched this spring. We had all these different things, talks I've given, talks other people have given, and put it all in one place on one website. So if you go to www.snmmi.org/dose, you'll see all kinds of information. It'll give you links to these two things, but also a lot of other information. So you might find some information there. And here are some other references. The discovermi.org, as you may have heard, is our patient-oriented website. You can get to that by either Googling that or going to our website, and you'll find it as well. And that's run by the SNMMI, and I just told you about snmmi.org/dose. If you look at this site, it has a lot of information. I think this website was put together by the RSNA, the Radiologic Society in North America, with a lot of patient-oriented information as well. You might find that very valuable as well. The Health Physics Society, those are the people who work in hospital, to radiation safety officers who make sure that we use radiation appropriately, and they have a public information site that you might find information about. I talked about image gently and image wisely. And also, if you're part of a clinical trial, you may want to check out this NIH website, an introduction to radiation for NIH research subjects. And if you go to this link, you'll find information there. So that's what I had to share with you today, and I'm happy to try to answer any questions you may have.
Yes, it is. I have a couple of questions. Just by way of background, there are a number of us in this room today who have had nuclear therapeutic treatment, PRT. We've had Ion-68 scans, and we've had CT scans, and probably numerous scans along those categories. Some of the information you provided seemed to imply that the CT scans were not cumulative. Is there any aspect of those types of scans where the radiation levels are cumulative, and you need to track those in some way?
Well, let me try to put it this way with respect to whether it's cumulative or not. The risk that you incur for each CT scan or PET scan or any radiation like that is independent. However, what happens is that if you get irradiated today, that risk, it's not the same quite as walking across the street, because you got across the street and you said, I made it today, and you know the risk, you either got hit or you didn't, right? With radiation, you don't know that, because the risk is now sometime from today to the rest of your life. So if you've had one CT scan, you have a certain risk. If you've had two, the risk for the rest of your life is twice that, right? But it's spread over the rest of your life. So, but having the second one doesn't add addition. It's not 3 times. It's the same as the first one. Do you see what I'm saying? So that's true of, and at least that's the current model that the experts in radiation health have decided, looking at all the radiobiological data, and about once every 10 years they get together and they say, this is what we think today is the best model to use with respect to radiation protection. And that's what we think today, is that it's linear. A small round radiation has, 0.1 millisieverts has 1/10 the risk of 1 millisievert, and that every exposure is independent. But it's a little bit tricky, as I'm saying, because it's not the same. It's not like you're going to get that risk today. It's like sometime, probably for 5 years from now to the rest of your life.
Well, the doses that we get when we have nuclear therapeutic treatments are quite a bit larger than any of those that we experience with the scan. Does it make sense for us to be keeping track? And I know our nuclear medicine doctor do that, but we kind of need to be cognizant of the total impact, because we are going through this over time.
So I think it is helpful to keep track, so that you can tell your doctor, I've had these scans. I had these CT scans, I had these PET scans, or whatever. Still, today, you come to your doctor, and your doctor's trying to decide how to treat you today. Then I think they have to decide just on today. Now, if you show them that you had 10 CT scans in the last week, then maybe you don't need one today. They could look at that. But if you had 10 CT scans 10 years ago, it's not really going to help them decide how to treat you today, and they should make a judgment on whether this scan today is going to be helpful to you. And the risk of this scan today is exactly the same risk, or maybe even a little lower, than the first one you got 10 years ago. So they should judge it, in my opinion, is on what's the value of this test today for this patient.
And is there such a thing as a threshold that some of us will hit? You know, if some of this has a cumulative value to us, is there a threshold?
The current thought is no. That there is no place where you get above some level and you've gone too far. That then the 30th CT scan has the same risk as the first CT scan.
From a scan or diagnostic perspective, but not necessarily from a therapeutic.
I mean, from a therapeutic, I mean, now you're talking sort of orders of magnitude perhaps different, but it's very focused, usually. So a very high dose to a certain area with a sort of, still a reasonable dose to everything else, but somewhat less than that. So the doctor, when they try to do the therapy, for example, I was just involved with a case with a 4-year-old with thyroid cancer, and how much radiation, iodine 131, should we give a 4-year-old with thyroid cancer? And so it's a tricky thing. We want to give enough to treat the cancer, not too much, right? So it's really a balance, and we did the same thing. We did imaging to get a better sense of where does it go in this patient, so we could make that decision. And so that's how we used it.
Thank you.
With this gentleman, and then I'll come back to you.
Two questions. So one, you haven't said anything about MRIs. Is there any radiation associated with MRI?
There is, but not ionizing radiation. So they work on the level of radio frequencies, like what goes into your radio to make you able to listen to music. So it doesn't have any ionizing radiation. It doesn't cause the same kind of damage that you're seeing here. But so it's a different. So in that case, it's not the same. And so, for example, if you had the money, a PET MR scanner, which is a lot more expensive than a PET CT scanner, might be good for a place like mine, pediatrics, where you could cut out the CT dose. The risks associated with MR scanners are contrast media has a very, very, very small risk associated with it, like any medicine may have a very, very small risk associated with it. And it's got a big magnet. And if you've ever had an MR scan, they spend a lot of time making sure that you aren't bringing metal into it. But those are the risks. There's a very, very, very small risk from the contrast media, and make sure you're not bringing a screwdriver in your pocket.
But there's no millisievert?
No, absolutely none. And ultrasound as well. Neither ultrasound or MR. So when the question that I said, ask your doctor, do I need this test, and how is it going to? And they give you an answer and says, oh, that sounds reasonable to me. It's not just, we just want to get we just want to get a baseline. Well, someday we might use. No, that's not a good reason to get a scan. I want to know how it's going to affect how you're going to treat me today. And then, is there another test you could do that will give you the same information that doesn't involve radiation? If they say MR would give us the same information, then you probably should get an MR instead.
You mentioned, actually, my second question was, you mentioned now a couple times ionizing radiation. What is ionizing radiation?
The energy and the wavelength of X-rays and gamma rays are such that they can knock the electrons off the atoms. And that that's what really leads to the damage we're talking about and possible mutations in the DNA. Because if it happens to be where it does that, is close to the DNA, then you could cause some changes that affects that cell, and then that cell could eventually, years from now, become malignant. So by ionizing radiation, we mean that radiation that has the energy and wavelength such that it can do that. It can knock the electrons off of the atoms within the tissue it's interacting in. The fact that it interacts at all, and so you can see the difference between bones and soft tissue in the lungs, it's the same reason it works is the same reason it can cause damage. So X-rays, gamma rays, positrons, they're at that level where they cause ionization. Radio frequency does not do that. It can make like microwaves can make the molecules vibrate, and that's why it heats up, but it doesn't knock the electrons off and thereby cause some kind of atomic changes that could lead, or molecular damage that could possibly lead to something deleterious.
So those are not ionizing?
They are not.
So MRI would be?
Non-ionizing, and ultrasound as well. Yes?
In the 60s and 70s, I was in the veterinary industry. Because of my strength, I was always in the x-ray room holding the animals. I've got non-Hodgkin's. Is there a way of measuring how much, because now I'm going through the symptoms now as well. Is there a way of measuring how much we accumulate in our body?
So, did everybody hear the question? This person said that in the 60s and 70s they worked in a veterinary lab, and they did radiologic exams on the animals, and someone has to hold the dog down, or the cat, or whatever, in order to do the test, and she did this. And so she was in the room when they were radiographing the animals, and now she has lymphoma. And is there a way to measure now what level of radiation she got then? And these days, I don't have one on now, but usually when I'm at work I do, we wear badges that measure the radiation. The apron? So so that measures how much radiation you got. At Children's Hospital, we put the badge under the apron as well. We put it here, and we make a correction for the fact that if it was under the. So it's different institutions do it differently. We wear it here and then make a correction. Some people wear two, one under, one over. If you had those records, you might have some estimate. The amount of radiation that you got was on that order of maybe 100 or 200 millisieverts probably in your career. So it could, you can't tell that this cancer was caused by this effect. So. The current model is that, that when I was in graduate school, that's what we sort of thought. You got irradiated, and then it sort of, for a while, and then your risk went up for a little while, and then after a while went back down. Looking at the people from Hiroshima and Nagasaki, it doesn't seem to be the case, or at least not for a long time. That there are still some people, very small number, who are still getting cancer from irradiation in 1945. That being said, that study, just as an example of this small effect, studied 100,000 people for 60 years, and what they've seen is something like 500 additional cases of cancer in 100,000 people because they had a bomb dropped on them. So it is a very small effect, as we've been talking about. Yes?
My question is a follow-on to the one that my husband asked, because he and many other people in this room have gone through both the diagnostics, which I understand is your focus, but also the therapy, which exposes them to radiation. And we have heard from some doctors that there is a concept of radiation poisoning, such that you get to a place where you can no longer have the therapy because it has poisoned your body such that you shouldn't have anymore. So I think that's why the questions are coming up about, should I track it, should I measure it? So have you heard, or are you aware or believe that there is such a thing as radiation poisoning that could ultimately affect a cancer patient's ability to have radiation therapy?
There's again, I didn't really address therapy in this talk. So, but just like any therapy, that's the way it works, right? It is poisonous, and you hope that it's more poisonous to the cancer they're trying to treat than it is to your normal tissues, whether it's chemotherapy or whether it's radiation therapy. Now, whether you get to some level where you've somehow got to a level that's difficult, in general, no. However, that being said, when you get these high levels, you can, your white cells might go down, and you may become, and some other things could happen. When we're treating some children with neuroblastoma, And it's it's a sad disease, and they're not going to they're not going to live to be adults. These kids, some of the kids with neuroblastoma do, but the small fraction that do not respond to therapy don't. We give them very high levels of iodine 131 to treat them, and in some cases we give them such high levels we have to give them stem cell transplants to get their white cells back. So, so in general, it's not the case, but your doctor can decide whether it hasn't been that effective before. I'm not sure it's going to be that effective now, or that but that's a medical decision to talk to your doctor about. But there's no such thing that you're going to get to some level that you've got so much radiation that one little bit more is going to put you over the edge. Sir. I can. As you can, one of the things that happens when you have a very, very sensitive test is, and you can, it's like you're looking at some kind of test and you're trying to determine whether, I showed you some examples, and maybe whether this patient has a tumor or not. When it's really, really bright in the lung, like I showed you, you won't have it. That's probably not going to be a false positive. That's really a positive. But let's say it was not quite that bright. It was a little bit brighter than it should be, but not a lot brighter. Do I call that or don't I call that? If the doctor decides to call it, then he might be right, but there might be some fraction of the time that it's just some normal variation of tissue that, for whatever reason, we don't know, that's normal tissue, but it had a higher glucose uptake that day. We tell our patients, for example, don't exercise for 24 hours before you get it, because your muscles are going to take up the glucose is a really good way to get fast energy, right? And so your muscles are going to take it up. And that may make it hard to see something if they're looking for something in the arm, for example. So that could lead to a false negative because it can't see it for some other reason. So, depending on how the doctor wants to call the test, they could be very strict and say, I'm only going to call it if it's 10 times higher than it's supposed to be. They're not going to get very many false positives, but they may get some false negatives because there may be some subtle cases that they miss from doing that. So the doctor tries to optimize that by having their threshold of where they call it someplace where they minimize both. High enough that they can see that it's a positive scan, but low enough that they're not calling a lot, that they're not missing a lot that are negative. I don't know whether that helps you or not. Well, I'll have to plead the physicist fifth, where I'm not a physician, so that's not the area of my expertise. So I apologize, but I can't answer that question, except in very general sense. I can tell you, like I said, I can tell you generally, but I can't really comment on your particular case. I'm sorry. Again, that's a good conversation to have with your nuclear medicine physician and your referring physician to say, well, if that's the case, then what do we then do, and how do we move forward on that? So again, that's a difficult thing for me to ask, but very good. Don't be afraid to have those conversations with your referring physician and your. And I can see Dr. Freeman's here, and that probably means that I'm supposed to quick. So if I have one more quick question, I think someone else. Very quick. The dose to patients is determined because we have models. Certainly didn't go into that, but we sort of have models of if you give this, let's say FTG. We know some of it in normal situation goes to the brain, some of it goes to the heart, some of it goes to the lungs, some of it goes to the liver. And then from that, we make a model of this is the average size person, and then we calculate how much of radiation dose went to all the different organs because of that. And then we make some estimate. How good is that estimate? Could be off by a factor of 2 for a particular patient, you know. But, you know, so when I said 4 millisieverts, could be 6, could be 2. How much radiation you were injected with and your size. How big are you? Thank you very much.